So why a global report now? As you know, before the 1980s, we knew that hepatitis was a big problem, but there was very little that could be offered. And as somebody who grew up in the clinical field in liver disease, I like to remind people that in the 1990s, when the WHO started to say, oh, we could vaccinate everybody with hepatitis B vaccine, that would be something that could lead to elimination of transmission. As a medical student, I was like, this is impossible. I can't even afford this vaccine for myself. How could we give it to everybody around the world? Yet it did happen. And maybe it actually sounded more impossible then than it does sound challenging today to eliminate hepatitis as a public health threat with testing and treatment of 5 core interventions. So in the year 2000, there's been really a takeoff in the prevention, particularly with hepatitis B, thanks to the support of Gavi. Then blood and injection safety has been really given a real push, and also harm reduction has gained more momentum. But since the 2010s, the elimination movement has really started, certainly stimulated by the availability of the direct-acting antivirals that were registered and the WHO resolutions that finally led to the decision to go for elimination in 2016. So we thought it'd be useful to know where we're starting from and to have a baseline. So this, in fact, represents in a graphic way what we're supposed to do between now and 2030 to eliminate hepatitis as a public health threat. So eliminate, for those of you who are not familiar with the definition, is really reducing incidence by 90% and mortality by 65%. So what I call the source code of the elimination strategy is actually based on some modeling work that says that if we were to actually reach this service coverage for these core interventions, which include hepatitis B vaccination, PMT-CT for B, blood injection safety, harm reduction, and testing and treatment, if we reach that level of service coverage, then we would be likely to reach elimination as defined. So in the next few minutes, I will be sharing with you what we think is the current situation at the baseline, the starting point in 2015. So how did we prepare this report? Our core idea was to give a baseline in terms of the 5 strategic direction of WHO and also the 10 core indicators. So we've worked on B estimates. For B, we've worked with the London School of Tropical Medicine and Hygiene and John Edmonds. For C, we've worked with the Center for Data Analysis, which some of you may know under the name of Polaris. For the B and C cascade, we've also worked with Polaris. For mortality, we've actually worked with the WHO statistics group and their new data from the global health estimates. And of course, some of these new methods have led to changes in the estimates. We have more specific criteria. It's been referred to the fact that now we focus on viremic and not only people with antibodies for C. We have more data available, more surveys, better systematic review, and more advanced analysis. So this is why our estimate keep changing, and hopefully it's as we go towards a more quality estimate. I will start with the prevalence and incidence. I will start with B, and I think it's really important. Some of us, went to medical school and look at this map of endemicity, showing the prevalence of surface antigen in children under 5. And I think it's quite amazing to think that with hepatitis B vaccination, we've actually redrawn that map, and that now the prevalence has really gone down from an estimated 4.7% in the pre-vaccination era to 1.3% today. So that means that really in terms of hepatitis B, the epidemic is definitely on the decline, and with the cohort effect, we're going to see less and less chronically infected people. However, today, we still have 257 million people that are living with HBV, and that some of whom are in need of treatment with, as you know, the majority of them that live in the Western Pacific region and the African region. In terms of C, this graph summarizes the situation in terms of incidence and in terms of prevalence. In terms of incidence, we estimate about 1.75 million new infections per year. mostly because of unsafe healthcare and injection drug use. The epicenter of transmission is mostly around the Eastern Mediterranean region and the WHO European region. And in terms of prevalence, we estimate about 71 million of people chronically infected. And you can see quite a difference with the B distribution, because in fact, for C, it's quite heterogeneous across all the WHO region. So it's, the epidemic is a little more heterogeneous within region and sometimes within countries with what some people call the hotspots. Here you can see a graph on mortality. So it's a bit hard to follow. Let me try to explain how it works. So we estimate that in 2015 there was 1.34 million deaths. And on this graph you can see by WHO region the death rate, the mortality rate per 100,000. And the pie chart represent the breakdown between HAV, which is barely visible in pink, HBV, which is in blue, HEV, which is in green, and C, which is in red. So you can see that in terms of mortality rate, the highest rates are in the Western Pacific region and the Southeast Asia region, and that the distribution of the mortality between B and C is not exactly the same by region. So, of course, in the Southeast Asia and Western Pacific, we have mostly B, but in the Eastern Mediterranean and in the European region, we have mostly mortality because of C. Now we'll talk to you about the prevention indicators, starting with hepatitis B vaccine. So as I've referred earlier, the vaccination for hepatitis B is a massive success story. So you can see here between 1990 and 2015, the estimated 3-dose coverage. We estimate that we have reached 84% in 2015, with a certain amount of heterogeneity that remains, but definitely an acceleration in the recent years. So the next challenge is, of course, the hepatitis B birth dose. The estimated global coverage is 39%. And here I've trimmed the graph a little bit because otherwise it was a little harder to read. But it's really spectacular to see that the Western Pacific, of course, because of the massive problem that they have in mortality, has been extremely proactive in pushing for the timely birth dose. America has also, despite much different burden, but probably a much stronger immunization systems, as we all know. So I think our next challenge will be Africa, because we're roughly at 10% for Africa, and Africa would definitely benefit from higher birth dose coverage. On one side, to reduce further the incidence of chronic infection in children, but also, and maybe most importantly, as suggested by the recent data from the Gambia, to reduce the proportion of children who actually acquire those infections that will require treatment later in life. In terms of blood and injection safety, I'll focus on unsafe injections, and here these are data that unfortunately are getting old. From 2010, there's been really tremendous improvement in the frequency of unsafe injection between 2000 and 2010. However, there's still an unacceptably high proportion of unsafe injection, and probably the biggest problem being reported in the Eastern Mediterranean region. If you're not familiar, we have a very active group at WHO that works on the safe healthcare, and they've launched recently a campaign that's called Get the Point, and that focuses not only on improving the safety of injection, but also on reducing the frequency of unnecessary injection, because that's really the accelerator. So for those of you working in country where you think that this may be a problem, I would really encourage you to go on that website. You can download all kind of patient material, doctor material to reduce the frequency of unnecessary injections and improve that situation. Now I will come to the last but not least of the prevention intervention in terms of harm reduction. So here we really have very problematic situation. On the left-hand side, you can see the estimated population of persons who inject drugs by WHO region. So we estimate 12 million PWID worldwide. So this is the last data that's been endorsed by WHO last April, but of course, we're all familiar, there's been a new paper released with, 2 weeks ago, which we haven't yet sort of put in our official communication material. So this is also outdated. So you can see the largest number are in the European, Western Pacific, and American region. But where it becomes really problematic is in terms of the prevention indicators. And you can see that whereas we would like to shoot for 300, without pun intended, for 300 in 2030 or 200 sets per injector and per year as target, where the global estimation is still at 27 in 2015. And again, it's also the distribution of syringe and needle is only a surrogate indicator, because we all know that the harm reduction package should be more comprehensive and include 9 core high-impact interventions. Now we'll switch to testing and treatment. And as you know, the price of antiviral medicine has been decreasing rapidly. It's been really a free fall, but we can go further. In terms of hepatitis B, this is really often overlooked. And particularly here, I would like to attract the attention of those of you working in countries that have access to tenofovir as a generic medication, because it's almost the entire world minus high-income country, China and Mexico. So if you're not in a high-income country, not in China, not in Mexico, if you do optimized procurement through the public sector, you can access tenofovir at $28 per year, which is a massive opportunity to address this mortality toll that we've talked about. In terms of hepatitis C drugs, there's been a lot of fall, and we can definitely go further. How does that translate in terms of the cascade? So these are the new cascade number that are slightly different from the one that you will see in the report, because these are the latest number for the year 2016 that we've released at the summit. So for B, we estimate that, of course, the majority remain undiagnosed, but there's been a bit of a progress in treatment coverage, because now we estimate 4.5 million on HBV treatment in 2016 compared to 1.7 in 2015. So really a progress, particularly through an increased access to treatment in China. However, as you know, most people remain undiagnosed. In terms of C, I'm not going to elaborate because these data were also just shown. So the total number has slightly reduced from the 71 million because of the death and the cures, about 20% diagnosed, but we're actually now at 19%, because precisely we're going to run out of patients slowly by these cures, and also an increase in the number of people starting treatment, 1.76 million that started in 2016. And we'll have to understand the cascade for C functions slightly differently from the cascade for B, and that's something I'll refer to in the next talk. In terms of equity, what we try to communicate also is that unlike HIV, which has a certain number of what's been referred to as key population, for hepatitis, we try to explain that incidence, prevalence, and vulnerability really differ according to viruses and groups. So rather than labeling people as key population, we would really encourage you, if you work in a country, to use your epidemiological data to see if these groups are at higher risk in terms of higher incidence, higher burden in terms of higher prevalence, and look as to whether the situation is the same for B and C. And when you look at the data, you will see that healthcare workers, persons who inject drugs, indigenous population, prisoners, migrants, blood donors, MSM may have very different profiles. Migrants, for instance, very often will have a high prevalence, but not a high incidence. Whereas healthcare workers in some setting tend to have a high incidence, but they will not necessarily have had enough accumulated incidence over time for this to result in high prevalence. So rather than these blanket statement that would apply everywhere. We really encourage you to find out where your epidemic is, understand it, and adapt your prevention to those groups at high incidence and your testing and treatment to the group at high prevalence. One of the biggest, I think, achievement of the summit 2 weeks ago in Sao Paulo, and I think it's going to be echoed in some of the discussion at this meeting, is progress on the way we want to conceptualize financing. And I think what was said in Sao Paulo is that maybe hepatitis could inaugurate a different way to think about healthcare financing, and rather than thinking about vertical sources that may turn into problem in terms of sustainability, we want to really integrate that in the universal health coverage. So here's an example from Mongolia, where you can see that really the financing of testing and treatment is being taken care of within the health care service package, with 98% of the population that's being covered, about 60 to 80% of the treatment that's being reimbursed, and also coverage in the public and the private sector. Our last strategic direction is around innovation. So one message we're trying to communicate is we have almost everything we need to eliminate hepatitis. We have a very powerful product, but we still need a little bit of innovation, and we need to push that innovation to those who need it the most. So we, as the price have been falling for treatment, the next bottleneck is definitely going to be diagnosis. So we need better point-of-care tests. We probably need a functional cure for HBV and an HCV vaccine, as this was just mentioned. But most importantly, at this stage, we want downstream research. We want to push all these new products with trial, field assessment, and service delivery models so that these innovations can reach those that need it the most. So as a summary of this, here's an overview of the graph that I showed you with the gray bar, which is our mission, should you wish to accept it, by 2030, and where we are in 2015. So we're doing good in Hep B immunization, blood injection safety, but in terms of burst dose, harm reduction, and testing and treatment, it's still the beginning. So the train has left the station. We'd like to be more of a 10% glass full rather than 90% glass empty sort of people, but we still have a lot of work to do. And this is happening fast. This is a graph that we showed 2 weeks ago in Sao Paulo. The number of countries with the viral hepatitis plan has been multiplied by 5 over 5 years. 82 countries, now 84 as of yesterday. So we're really moving forward. So as a take-home message, and according to our 5 strategic directions, I'd like to say that we have a global picture that's taking shape, that is still lacking the granularity at the country level. That's why we stayed at the regional estimates. We have gaps in prevention, testing, and treatment that need to be urgently scaled up. We want to have that as a public health approach and not something that's fragmented within the private healthcare system. And we want sustainable financing in the context of universal health coverage. And finally, we're really happy about all the super active research, but we think that it really needs to benefit those who need it the most at the periphery, among the poor, the marginalized, and those who are victims of stigma and discrimination. So thank you very much. And,